Thank you, Animesh, for the opportunity and very good morning to everyone. So it's a long topic. It's a newer paradigm of both adjuvant and neo-adjuvant treatment in resectable lung cancer. I think topics that's made my job very easy. Many of the trial is already been discussed and resectively what are actually the resectable lung cancer, including the SSC9 has been discussed. So I'll go through my slide deck. So this is my disclosure. So I'll discuss about neo-adjuvant, adjuvant ICI in resectable NSCLC. Then perioperative, we'll touch on perioperative. Then adjuvant TKI in both EGFR and ALK rearranged NSCLC. And then what is the ongoing study for other rare entity, both in adjuvant and neoadjuvant setting. So this is the evolution of systemic therapy. If you see, these are the target, this green bar is the target therapy. This is the neoadjuvant chemotherapy, and this combination is the neoadjuvant chemoimmunotherapy. So we have data on Keynote 091, ADURA study, and ELENA study on the ALK, both in the adjuvant setting. Then we have two clinical trials, both in atezolizumab and pembrolizumab in a adjuvant immunotherapy setting. And we have lots of data, at least the 6 clinical trial in perioperative, the Keynote 671, AGR, NeoTorch, Checkmate 77T, and the Rational 315 with the 2 newer anti-PD-L1 agent. So which is resectability? I think we have a lots of discussion in the last panel discussion. So single station, non-bulky, non-invasive is definitely resectable. Multi-station, non-bulky, non-invasive is definitely resectable. And we avoid the resection in patient with a multi-station or single station but bulky and invasive. So this is the SSC9. I think there are lots of area for debate and discussion, but at least these are the area where these are potentially resectable, and that too depends on the surgeon experience, the thoracic oncology and the surgical oncology care for a big center. So not all center are equipped with doing surgery in a multi-station N2. And definitely MDT approach is required. Each and every patient should be discussed in MDT, and only the upfront resectable patient should be considered for perioperative immunotherapy. There is nothing called borderline resectable in lung cancer, which is either resectable or unresectable. It should not take chance by giving neoadjuvant chemo in a borderline resectable cancer. So why adjuvant? Coming to the, because the trial came initially the adjuvant setting, then moved to the neoadjuvant, then the perioperative. Now, we know that upfront surgery reduces the risk of tumor progression. There is almost 20% of patients who didn't undergo surgery in a neoadjuvant approach. It avoids treatment-related toxicity and reduces the surgical complication from the neoadjuvant treatment. But on the same time, there are other advantages of neoadjuvant and perioperative. I'll come to the later. So this is a 3 trial done in adjuvant setting. This is IMPOR 1010 is an adjuvant atezolizumab with a PD-L1 tumor score of more than 1%. Then we have Pearl study or Keynote 091 of pembrolizumab. Both has a DF plus minus temolizumab. Now, these 3 trials, out of these 3 trials, these 2 trials did show PFS benefit, and at least the Keynote 091 has OS benefit, early OS benefit also. Unfortunately, the BR31 didn't show any benefit. And this is a 3 trial comparison. Almost all patients received 3 to 4 cycle of adjuvant chemotherapy. The control arm was best supportive care, and they received 1 year of adjuvant therapy. These are the different stratification factor. So this PD-L1 platform was different. The cutoff was different because those depend on the company and diagnostic. So the platform and the clone depends on which immunotherapy you are using. And these are the primary endpoint. In almost all trial, DFS was the primary endpoint, including whole group or high PD-L1 positive group. And OS was definitely secondary endpoint in almost all the clinical trial. But this BR31 was a negative trial. We do not know the reason, but this is the only trial where the nodal dissection was done according to the ESTS guidelines. Otherwise, all the clinical trials, they have used the nodal dissection. We do the systematic lymph node sampling during the surgery, in a thoracic surgery, but at least 3 stations should be touched, and at least 7 lymph nodes should be removed during the thoracic surgery. But this is the trial who did follow exactly the European Union guidelines. And if you see the median DFS in the placebo arm, in the IMPOR, it was only 35 months. Keynote 1, it is a 42 months. But in the BR31, a patient who didn't receive even immunotherapy has a median DFS of 60 months. So is this the reason that the good surgery is done, the adjuvant immunotherapy is not required? Because this is the only trial where the surgical discipline was maintained as per the guidelines. Now, DFS difference among the different magnitude. What is the outcome in patient with a PD-L1 high? So these are the three trials. The primary endpoint was DFS. If you see the hazard ratio in PD-L1 high group, in the primary BR31, the hazard ratio 0.93. In the pembrolizumab group, it is 0.82. The maximum benefit was in atezolizumab group. So again, even in PD-L1 high subgroup, the trial showed benefit. So coming to these three trial of adjuvant immunotherapy, the PD-L1 more than 50% predict the DFS and OS benefit from both adjuvant and atezolizumab, but unfortunately, there is no benefit in the pembrolizumab DFS in PD-L1 unselected population. But if you see the subgroup, it didn't have benefit in PD-L1 high. On the contrary, all the stage 4 study, we shown that immunotherapy has a best effect in PD-L1 high. Adjuvant durvalumab did not improve DFS in any subgroup, but has an excellent outcome in placebo arm due to the good surgery. And the magnitude of benefit from this immunotherapy increased with as the PD-L1. So as of now, for more than there are three studies. We all know that Nadim-1, Nadim-2, and the Checkmate 816. Nadim-1 was the phase 2 study of 3 cycle of neoadjuvant Nivo plus chemo. Nadim-2 was phase 3 study. So the result from the Nadim was validated in Nadim-2, and then it was further validated in Checkmate 816. To be noted that in the Checkmate 816, we give chemo for 4 cycles, but nivolumab for 3 cycles. This is Nadim-2 design. It is a neoadjuvant chemo immuno versus only chemotherapy, followed by surgery, followed by 6 months of adjuvant nivolumab. And if you see the PathCR rate, PathCR was higher. The primary endpoint PathCR is 36% versus 6%. Absolute benefit, there is an odds ratio of 7. And if you see the PathCR rate, the PathCR rate increases as the PD-L1 TPS score increases. So the maximum benefit, at least from this trial, as per the PathCR is a concern, this was the primary endpoint that patient did benefit with a higher pathological CR as compared to chemotherapy alone, and most benefit with the whose PD-L1 score was higher. But as of now, we do not need PD-L1 score to start the therapy, but it helps in prognostication. This is a Checkmate 816 study, the Nivo chemo versus chemo followed by surgery, followed by no further adjuvant therapy. So this is a pure neoadjuvant chemoimmunotherapy trial. Again, if you see the primary endpoint of EFS was higher, hazard ratio is 0.63, including the PathCR rate, 24% versus 2% in the whole cohort. And this graph is important. See, this patient who achieved PathCR, whether in chemo versus chemoimmuno arm, they had a better outcome versus those patients who did not achieve PathCR. So irrespective of treatment, the achieving of PathCR is most important for a better EFS and probably for a better OS. So the questions come, if the patient achieve PathCR, does they require further adjuvant immunotherapy? I'll come to that. Now, we have discussed adjuvant plus neoadjuvant. Now I'm moving to the perioperative chemo. This is a very busy chart. I think Tapes already shown. So this is a comparative study design from all the 6 clinical trial. This is the Checkmate 816. It's a pure neoadjuvant chemo immuno. Checkmate 770, where the patient received adjuvant nivo for 1 year. This is a keynote study of pembrolizumab. This is the AGN, our own AGN study for durvalumab. This is Neo-torch with a toripalimab. And this is a rational 315 by tislelizumab. Now, if you see, almost all the study received neoadjuvant chemo 3 to 4 cycle. Post-op chemo was not required because they have received adequate neoadjuvant chemotherapy, and carboplatin was also allowed. And majority patient trial excluded EGFR-ALK. AGN study initially included EGFR-ALK, but subsequently it was removed. This is the cost trial comparison. If you see, the PathCR is almost similar. It is between 17 to 20%, except the rational, the tislelizumab PathCR was 40%. And if you see that 24-month EFS OS, almost similar in the range of 60 to 70%. And this is the comparative. I think if you see the hazard ratio from all the 5 trial, almost similar, except the rational one, the Neo-torch one. But in all sense, this PD-1 and PD-L1, they are almost a similar group. So what you have learned from this 6 phase 3 trial, the PathCR rate significantly improves from less than 5% to 70 to 40% when we combined with chemotherapy, immunotherapy. Addition of perioperative chemoimmunotherapy significantly improved the EFS. Approximately 1 in 5 patients didn't undergo surgery. So this is one of the drawback of perioperative immunotherapy. 16 to 20% didn't undergo surgery. So achieving a path CR or CT clearance is the most important predictor of improved survival. Now, this is the meta-analysis from all the trial. Both the stage 2 and stage 3 patient, they did get benefit from all the trial, but the maximum benefit was in stage 3. That's why I said even the multi-station intubation derived the maximum benefit from the perioperative chemoimmunotherapy. Does the PD-L1 score matter? Probably not. Even if this is the again the meta-analysis, if you see the PD-L1 score, this is 0 versus 1 to 40 and 50%. Almost all subgroup did benefit from the chemoimmunotherapy, irrespective of PD-L1. How should you choose between adjuvant and perioperative? Even for a PD-L1 high, I think you cannot do a cross-trial comparison. As of now, we have the best robust data for perioperative chemoimmunotherapy as far as the PCR and the EFS is concerned. So this is the, in general, we have neo-adjuvant, we have adjuvant, we have perioperative. Should we continue ICI for a patient with every patient irrespective of PATH-CR? The data showed that those patients who received PATH-CR, they had a better outcome irrespective of immunotherapy. But I think the ctDNA clearance is more important than the PATH-CR. And there is a great debate in published in JTO. The ctDNA result is coming this year ASCO. And that shows that the ctDNA clearance at cycle 3 day 1 is a best predictor of our outcome, even better than a PATH-CR. Now, moving to the adjuvant treatment in the EGFR ALK, we all aware of the data. These are the 5 clinical trial, very unselected population that didn't show any survival benefit of adjuvant TKI after surgery. And then the data come for this ADAURA trial. We all know that ADAURA have a DFS and OS benefit, both starting from stage 1B to 3A, and also OS benefit, including the excellent CNS DFS benefit in patients with a resectable lung cancer who are EGFR positive and received adjuvant osimertinib for 3 years after completion of chemotherapy. This is the latest NEJM article last year published for the OS data of ADAURA study. And if you see, patient of 1B to 3A or 2 to 3A all achieved a better OS, even the see the hazard ratio 0.5, 50% reduction in death in adjuvant setting. That is a great with adjuvant TKI. Whether patient receive adjuvant chemotherapy or not much of difference. The crux of the matter is that patient should receive 3 years of adjuvant osimertinib. Now, what is the role of neo-adjuvant osimertinib? These are the 3 published data from the NEOS trial and NORA trial and another multi-centric trial. I have compiled the data. The patient receives 6 to 8 weeks of neo-adjuvant osimertinib, mostly from the stage 1 to 3A. But if you see the PATH-CR, 0 to 4%. Unfortunately, we see the great response even in stage 4 setting. Patient with single agent osimertinib achieving almost complete response. But unfortunately, single agent osimertinib almost not achieve any PATH-CR in a neoadjuvant setting. Currently, this neo-adjuvant trial was ongoing. We are at the part of this trial at Tata Medical Center, Kolkata. The study has completed the recruitment. We'll expect that data will come very soon. So this study has a osimertinib versus chemotherapy versus chemo plus osimertinib. So we'll get what this arm shows, chemo plus osimertinib in a neoadjuvant setting. Very quickly to the ALK positive, we all aware of the ALENA trial that the study is published in NEJM and showed that adjuvant alectinib for 3 year duration has a better DFS and OS outcome. This is intent to treat population. This is whole group. Excellent PFS, EFS benefit or DFS benefit, hazard ratio 0.24, 80% reduction in recurrence. So this data is almost similar to osimertinib, but for a limited follow-up, the OS data is yet to mature. So I think very soon this also will come into practice of using adjuvant alectinib in patient with a ALK positive lung cancer after surgery. This is the ALENA DFS endpoint. Almost all the primary endpoint has a much, if you see the hazard ratio, almost all in 0.2 range. This is the forest plot. And this is also again just like osimertinib, very high CNS DFS. Very quickly move to the neoadjuvant ALK. What happened? Because we discussed the neoadjuvant osimertinib. So there are the 3 publications for neoadjuvant crizotinib or encertinib or alectinib. I have compiled the data. So there is a data from neoadjuvant crizotinib for 11 patients, 30 days of median duration. Almost all patients underwent surgery. PATH-CR is good, 18%, single agent crizotinib. Another one is from the ATS study, alectinib and crizotinib. Almost 3 months of neoadjuvant TKI. PATH-CR as high as 37% with alectinib, 15% is crizotinib. So this trial is currently ongoing, the Neo-cast study of the encertinib, neo-adjuvant in ALK positive resectable lung cancer. So I think again, this field is also going to change just like EGFR positive lung cancer. We'll very soon see maybe neo-adjuvant ALK TKI in ALK positive resectable lung cancer. So that's why it's important to do EGFR ALK each and every patient so that we do not have to give immunotherapy, which is a futile effort. So this is a phase 2 study of what happened to the other than ALK, ROS1, NTRK, and BRAF, because we always discuss one EGFR. So this study is currently ongoing, is discussed in WCLC 2020. This is a basket trial. So patient with ALK positive receive alectinib, ROS positive receive entrectinib, NTRK entrectinib, BRAF receive vemurafenib and comitinib, RATE receive pralsetinib. So all the patient, depending on the biomarker, receive respective TKI for 6 to 8 weeks of duration, followed by surgery. And we are waiting for this data to come. What is the PATH-CR and the EFS? So patient will receive neoadjuvant TKI, followed by surgery, followed by adjuvant chemotherapy, and 1 year, at least 2 years. And this is another trial, Liverto 034. This is a phase 3 study of adjuvant selpercatinib in patient with important. Again, as we discussed, that it is the time now to move beyond EGFR ALK ROS1 even in resectable lung cancer. So if someone asks whether should we restrict to EGFR ALK ROS1 or whether move to NGS, I think it's better move to NGS. We all know that molecular addicted lung cancer beyond EGFR ALK ROS1, they also do not respond to immunotherapy, and that's why this trial currently ongoing for respective molecular positive lung cancer with the respective TKI. This is a very exciting study for RATE and NTRK because we know the outcome is very excellent, even better than ALK and EGFR with selpercatinib. So this is the key consideration of choosing neoadjuvant, adjuvant, and perioperative treatments. High volume center, surgical experience, medical oncology, pulmonology, and MDT approach. Patient preference, ECOG performance status, comorbidity, and of course the patient choice and the patient autonomy. And whether the drug is accessible. We have many trials, but as of now, drugs are costly. So accessibility is an important issue. Reimbursement is an important issue in many countries. And stage resectability, PD-1 TPS, and the oncogenic driver. So this everything should be taken into account both for the accessibility, the tumor characteristic, the patient characteristic, and the expertise. And you choose your therapy at best. So this is the summary. Incorporation of the immunotherapy in early stage NSCLC has improved survival outcome. Tumors with high PD-L1 score generally derive more benefit from adjuvant, neoadjuvant, and perioperative immunotherapy. And the perioperative immunotherapy, chemoimmunotherapy likely to gain traction given the consistent benefit across the all subgroup. We cannot identify patient for neoadjuvant therapy without any upfront biopsy, and biomarker selection is very much important. Adjuvant osimertinib showed significant DFS and OS benefit. The question is, what should be the optimum duration? Should we stop at 3 years? That debate is still ongoing. Again, adjuvant alectinib showed significant DFS benefit. OS benefit is awaited, but we do believe that this amount of magnitude of DFS benefit will result in OS benefit just like osimertinib. And initial result is disappointing with the single agent neoadjuvant osimertinib. And all the other rare subgroup, the adjuvant neoadjuvant study is ongoing. So I'll stop here. Thank you very much.
Thank you, Dr. Ghosh. That was a brilliant discussion you just now had with us. And I'm sure most of us agree that Dr. Ghosh has very cleverly brought all controversies to a consensus mode. Thank you.
Thank you, sir.
Now, I think we can have 1 or 2 questions from the audience. Any questions from the audience?
Osimertinib in EGFR mutant cases or on all?
Will you take the mic, please?
Osimertinib in only EGFR.
Only mutated patient.
Only mutant.
The common mutation, the del19 and EGFR21.
Is there, for EGFR non-mutant cases, is there any adjuvant therapy trial on
That we discussed now, adjuvant
Alectinib.
immunotherapy and chemoimmunotherapy.
alectinib?
No, alectinib for ALK1, ALK positive.
ALK positive.
For rest, no EGFR, no ALK, we are following this perioperative chemoimmun approach. Thank you.
So if there are no more questions, thank you very much, Dr. Ghosh, once again. Oh, there is one. I can't see him.
Yeah,
Please come forward. Yes.
Hello. Yeah. Sir, I couldn't resist this question. Do you think in some foreseeable future, we might totally give away with lung surgery, radical lung surgery with an good drug to ALK or EGFR. What is your what
As
does
of
your
now,
principle
probably
say?
not, maybe in
Not
near
now.
future, probably not, maybe in distant future. So the question come, any patient with a stage 1B or 2A patient who achieved complete radiological response and the ctDNA negative. Can we avoid? In few cases, probably yes, but I am not have the liberty to say as of now.
You are meaning surveillance in those cases.
Sir?
You are meaning surveillance in those cases without going for surgery.
No,
You
as
are
of now, we are
giving
doing surgery.
new
As of
adjuvant.
now, we are doing surgery.
But
Sir,
if there is
We
complete
have talked
pathological
later
response,
today about lung saver, and I think we have quite a few radiation oncologists are there. They can pitch in for that.
The question
Without-
is to avoid
No.
local therapy,
Yeah.
not even radiation.
if there is pathological response, total pathological response,
So
It-
for pathological response, if someone we have already planned for perioperative, I am continuing the adjuvant immunotherapy because even in patient who receive PATCR, if doesn't have ctDNA clearance, they have a high chance of recurrence. So the data is yet to come.
no, I'm talking about surgery. I'm talking about surgery. In case of lung, like in other cases, like in breast, we are diminishing the extent of surgery by giving neo-adjuvant therapy. But in lung, what you have to do, you have to either do a full-scale surgery or don't do surgery. There
Surgery.
is no scope of doing any compromise surgery. That's what I mean. So
So as of now, we are giving neoadjuvant therapy followed by surgery who are resectable and fit.
followed by surgery. There is
Thank
no
you, sir.
question of
We'll have a
surgery.
group photograph before we move on to the next session. Sir, please come forward. Thank you, Dr. Bivas Biswas, sir, for such an intricate presentation on this very difficult topic and emerging topic.